Good evening, friends, colleagues. Thanks for taking the time to join us today. Our topic of concern today is bipolar disorders, and we are privileged to have you with us. We'll run this for the next 3 days, and our presenter is Dr. Kemi Bhatkunda, and I'm the moderator of the next 3 days. My name is Raymond Mugume. And we know that bipolar really has lived with us. We just need to understand it more. A reminder is that feel free to drop in any questions or comments in the chat as we go along. And at the end of the session, Dr. Kemembe will be glad to answer those questions. I acknowledge everybody who is taking in the time to again join in. And without further ado, I would like to start us off with Dr. Kemerembe bringing us to why are we here today.
Thank you very much, Dr. Mugume. Thank you, Dr. Mugume. Thank you, everybody who has joined us, ladies and gentlemen. You're welcome to this week's edition of the neuroscience training, peer-led neuroscience training. Dr. Moses, I'm holding on for you. So I welcome all the residents in psychiatry and in other specialties and faculty that may be present, and the medical students, you're all very welcome. So this week we are going to look at bipolar disorders, and my screen will be shared shortly. Specifically today, we shall discuss the history of bipolar disorders, the different definitions we use, the diagnosis, and the epidemiology or burden of bipolar disorder.
I'm sharing your screen already. Dr. Kemi, I am sharing your screen.
Some volunteers to let us in on what they think bipolar disorder is. What's bipolar disorder? This is a question we are going to be asking the whole of this week. And bipolar disorder is a chronic.
Dr. Kemerembe, can we have the presentation shared? Okay.
It is shared on the screen
Moses,
now.
So maybe as Dr. Kemerembe gets back on board.
This disorder is heritable and it presents with both psychiatric and non-psychiatric comorbidities. And it's usually difficult to diagnose it in clinical settings because of overlapping symptoms with other disorders. For example, there are disorders that cross the schizophrenia spectrum because they share psychotic symptoms with bipolar disorders. It can create confusion around diagnosis. And also with the mood disorders, the depression, it can initially be difficult to tell whether it is a depression occurring within bipolar or it's a major depression occurring on its own. Considering that many times.
I think we have lost Dr. Kemerembe with the network.
Right corner, there has to be an episode of mania, and this may or may not be associated with depression. And sometimes there are episodes of hypomania or episodes with mixed features. But the rule is to diagnose somebody as having bipolar disorder 1, there has to be an episode of mania. And then for bipolar 2, there's always going to be one hypomanic episode and one depressive episode.
Dr. Moses, can you move the slides? Dr. Moses, please move the slides. We are still on the first slide.
We can go to the next, please. Yes, please, we can go on. I can just add that previously we were looking at the history, the historical factors, the family history, the history of substance use. But of recent, studies are considering things from cheerfulness to misery. So it may mimic because you are coming from an elevated mood to a low mood or vice versa. However, it doesn't cause as much impairment, and these fluctuations are not as big, as major as those of bipolar affective. And then in depression, we have a mental state that's characterized by excessive sadness. And depression can be either major depression, which is a serious mood disorder, and we know the criteria, but we shall revise them in the later slides. We have to have either loss of interest or depressed mood, persistently depressed mood, lasting 2 or more weeks. And you remember the 9 symptoms that accompany this: irritability, fatigue, poor concentration, sleep disturbances, weight gain, low or loss, weight changes, feelings of worthlessness, feelings of guilt, sometimes suicidal tendencies. There's also dysthymia. So the major depression, either we are going to have either major depression or subthreshold depression, which is a depressed mood or loss of interest, but the number of symptoms under the nine that I just listed, with subthreshold, they are less than 5. But with a major depressive episode, they are 5 or more. And then we'll have dysthymia, which is a permanent state of low mood.
Dr.
Yes,
Cameron,
please.
the slide
Yes,
that
Dr.
we are
Mukome.
seeing, the slide that we are seeing is for definitions.
Yes.
I don't know if that's where you are or
Put everything under depression, but I'm just expounding. We can go to the next slide.
Thank you.
I hope we are all at history now. I'll run over the history. Was told us about how we came from one whole jungle of symptoms classified together to the different classifications. So I'll just go briefly over it, that the psychiatric symptoms, specifically these, the mania and depression, were first differentiated as extreme moods in 460 BC. So in the 19th century, a French psychiatrist, Jean-Pierre, described a new disorder which he called folie circulaire. This is French for a cycle, a cyclical madness. The folie is like madness, which we don't really use in our vocabulary. But he simply meant that at some point of the cycle, somebody will have an extreme of mood. Either they'll be very high mood or very low mood. And then we have Carl, who came in and based the symptoms on the outcome as those that were very severe and caused limitations in function, and those which did not cause a lot of limitations, the Vacodia and Vesania, respectively. Then in the late 1800s, Kraepelin characterized the dysfunction of mood into what he called dementia precox. So by precox, he referred to everything: the psychosis, the depression, the mania, and he also it was later grouped into the precox and the manic depressive insanity, where this was what was later known as bipolar disorder. So after Kraepelin, the DSM was developed, and it separated the manic depressive insanity into mania, that is manic, depressed state, and other. And so we've had several changes to DSM-2, characterizing the disorder subtypes, characterizing schizophrenia as different and distinct from bipolar disorder. And then we later got hypomania coming in because the features were not as significant as those of mania. And eventually we have DSM-5, where the criteria for manic episode developed further specifiers that we shall also look at in the preceding slides. So as per our outline, we can move to the next slide, which is global prevalence. We look at the prevalence of these bipolar spectrum disorders across the lifetime, an individual's lifetime, and across a 12-month span. So For bipolar 1 disorder, the prevalence risk is 0.4% for 12 months, and across the lifetime, it's 0.6%. The highest is the subthreshold bipolar disorder. Bipolar 2 has 0.4 lifetime risk and 0.3. So estimates from the World Mental Health Survey report a higher severity of depressive episodes in low and middle income countries than in the higher income countries. So there's lower income itself. We have seen that lower income is associated with depression. So it's not surprising that for the countries that are low income states, 95.5% of the episodes are depressive, while those in middle income, 77.4% are depressive. So research also shows that the rates of comorbid disorders are significantly greater among those with bipolar 1 disorder and bipolar 2. We can go to the next. So now when we come to Uganda, Africa, in Africa, the lifetime prevalence is 0.1 to 0.6% overall. And the global prevalence, we looked at those different time periods, but overall, the prevalence rate is 0.4 to 1.4%. And bipolar disorder has been identified as the sixth leading cause of disability. We shall see the disability adjusted life years. And when it comes to Uganda, the surveillance data that had some information of bipolar disorder reported 24 per 100,000 people having depression. And this data was looking at not only the psychiatric disorders, but also the neurological disorders, which put epilepsy at the top, since the neurological disorders were also considered. And second to bipolar, there's schizophrenia coming at 26.6%. So you can see that 2/3 of the population in the psychiatric diagnosis is dominated from health center 4s, 3s, and 2s. And that taking the highest over 1,000 is epilepsy, and then followed by bipolar disorder, schizophrenia, and so on. The pattern is similar almost to what was seen in Butarika. We can move on. So when it comes to the epidemiology, the mean age of onset for bipolar disorder has been suggested to be early 20s. And there are some population-based cohort studies that were done in the US, which found two peaks. The first peak being at 15 to 24 years, and the second peak being at 45 to 54 years. Now, the late onset mania, this that occurs at 45 to 54 years, has been associated with higher risks of psychiatric and medical comorbidities. So we have the psychiatric comorbidities like suicidality, and the medical comorbidities like diabetes mellitus, heart disease, vascular disease, and this is more than in the young onset mania. There are also studies that suggest a shared genetic risk factor between bipolar disorder, schizophrenia, and autism. So there's going to be more need for research on the genetic and environmental factors, because the biological mechanism for bipolar depression hasn't really been very specific, which makes it difficult to determine the exact cause of bipolar disorder in an individual patient. However, these risk factors have been identified to increase the risk of BD. Childhood maltreatment, psychological stressors, substance use, as mentioned before, a higher socioeconomic status actually increases the risk of bipolar disorders, higher occupational levels, being unmarried, unemployment, and it has also been seen that individuals who are very creative are prone to bipolar disorder. We can move. And this one, we observe it at the universities. These students in the early 20s who sometimes develop the disorder are at their most creative, they are most vocal, And sometimes it's not noticed until late because they're actually benefiting from their creativity until they tip over and they actually become very symptomatic. But that is a risk factor. So when we look at the burden of disease for bipolar, compared with unemployed individuals, that we compared with employed individuals, the unemployed individuals have a greater severity of depressive but not manic symptoms, because we know that depression is tied to a lower income status, and you're more likely to have a lower income status if you're unemployed. Now, the employed individuals who have one major depressive episode miss more days of work per month compared with individuals who don't have depressive symptoms. And in the US, an estimated total annual economic burden of $195 billion was estimated to be attributed to bipolar disorders. That was between 2008 and 2018. There's no estimation for the Ugandan total annual burden, but we know that it is also very high because we have treated these people and we know how much it costs to have the mood stabilizer, the antipsychotic, to have their full regimen of treatment every day, every month. And the drivers of the increased cost include the frequent admissions, the interventions, which can include admission, the comorbidity, because sometimes you have to treat the bipolar disorder, but you also have to treat the substance use disorder or the physical comorbidity like diabetes or vascular disease. And then there are also indirect costs like unemployment, lost work productivity, because somebody having an episode is not going to be able to work. And this accounts for 72 to 80% of the economic burden. So when we look at the DALYs, the disability adjusted life years, over 8.5 million years are lost due to this lost work productivity caused by bipolar disorders. And when you aggregate it as a proportion of the mental disorders, it accounts for 6.8%. So we can go on. That we look now, that was the global impact, the impact on the economics, on the functionality, the impact of morbidity, mortality. But what about on the patient themselves? It's always important to look at them not as a case, but as an individual and study what effect is this disease having on them. First of all, they have difficulty accepting the diagnosis. There's a loss of hope. They don't know about how well the medication will be, how effective it will be. They have a bias towards the long-term treatment requirement. So they are very scared about that. That the diagnosis itself is overwhelming. The relationships are strained. They are not sure of the relationship with their peers, with family, and sometimes the healthcare professionals are not able to give sufficient support. So there's also the fact that this person is now seen as a statistic or as an individual or as a diagnosis, and yet they want to be seen as them, as an individual. Then they feel a sense of loss. A patient with bipolar disorder feels like they have lost control over their lives. They no longer have autonomy. They don't have confidence to present their feelings or their opinions. Sometimes they lose work, they lose sense of purpose, they lose their sense of social connection, and they actually lose their function. They're not able to do the things they were able to do before. They struggle to follow daily routines. They struggle to do schoolwork, to do work. Sometimes they are marginalized. So this is stigma. They are having stigma from their own peers, but also their view of themselves changes. Then they have this constant threat of the mood change. They don't know when it will, especially when they haven't been given adequate psychoeducation. They do not know when the relapse will happen. They are in constant fear that this mood is going to swing and they'll get into trouble. Could we please go to the next? I hope you're posting your questions. So apart from seeing these people as ill, they also have things that they have noticed about the positive attributes of having this disorder. There has been a well-documented association between creativity and bipolar disorder, and increased spirituality, resilience, and other traits have been observed in individuals with bipolar disorder. The other traits include empathy. They are more caring for other individuals, possibly because of their own diagnosis. They have an increased sense of self-awareness. So this is an opportunity for us to harness when doing psychoeducation. They can easily get very self-aware and be able to predict an episode. They have increased productivity. This is linked to the creativity, but also to the energy. They have increased self-confidence, which can be linked to the grandiosity, the euphoria. They enjoy being in that state of happiness, of excitement. They feel invincible. And sometimes, in some cases, the relationships, in very few cases, relationships with family and friends are enhanced. Some report feeling heightened experiences, for example, spiritual experiences, being able to be in touch with the divine. Those are things that the patient themselves view as positive aspects of the disease. However, in spite of all these positive characteristics that have been seen, some patients still say, 48% say that if they could reverse it, they would rather not have the disease. We could go to the next. We shall be looking at the diagnosis and classification of bipolar disorders. I hope I'm still audible, and I hope the screen can still be seen.
Yes,
Okay.
you're audible and the screen is still seen. Please go ahead.
Thank you very much. So this is the classification. I just wanted us to have this distinct in our minds, and then we look at the details in the next slides. Yes, I know we have bipolar 1, bipolar 2, cyclothymia, but we know that we majorly classify as bipolar 1 and 2. And for bipolar 1, the rule is that there has to be one or more manic episodes. And this can be preceded or followed by a depressive episode, but you cannot make a diagnosis of bipolar 1 without having a manic episode. Whereas for bipolar 2, we have one or more hypomanic episodes, and characterized by a distinct period of mood disturbance, manic symptoms, unequivocal change in functioning, less severe than they have to be less severe than the manic episode, so that we classify it as hypomanic. But we can also have a depressive episode. So we shall look at the details. This is DSM. So the manic episode, those are the criteria. I think we can all access this, but what we can note is that if a full manic episode emerges during antidepressant treatment, for example, somebody comes in with symptoms clearly, and you make a diagnosis and it's a major depressive episode. It's manic, it's a major depressive episode, and then you start the patient on antidepressants or you start electroconvulsive therapy. And then as you go along your treatment, a manic episode comes up and persists beyond the physiological effect of that treatment. So you're having an elevation of mood, but it is going beyond the physiological effect that the treatment should have had. In other words, you're getting mania instead of having a euthymic mood. That means there's sufficient evidence for a manic episode, and therefore there is evidence for a bipolar 1 diagnosis. So we have to be very careful, especially for the patients where the mood, the major depressive episode precedes the manic episode. Somebody will come and they actually do have bipolar, but because we are seeing features of depression, we end up treating the depression, but along the depression treatment, a manic episode comes up. It's enough evidence if they get an elevated mood and we fulfill criteria for mania. This criteria listed here, it is sufficient to diagnose as a bipolar 1. But like I said, we have to be very careful. We can go to the next, Dr. Mwangzi, where we have hypomanic episode, and it's a distinct period of abnormally and persistently elevated, expansive of irritable mood, and abnormally and persistently increased activity or energy, which lasts for more consecutive days and is present most of the day, nearly every day. That's criterion A. B, during the period of mood disturbance, we know these 7 symptoms. So 3 or more of these must have persisted or are present to a significant degree. However, in criterion A, if we had only irritable mood, out of these 7, 4 or more must be present. So we can go to the next, thinking that the criteria, we can always refer to them and actually also refer to the Neurotorium website as well. So major depressive episodes are common in bipolar 1, but we should note that they are not really required for the diagnosis of bipolar 1, as clearly shown in the figure we saw before. For bipolar 1, we need 1 or more episodes of mania. And this may or may not be preceded by a major depressive episode. So we have to be careful, because somebody may come and they're having a response to a significant loss. For example, a normal physiological response to bereavement, to financial loss, to natural disaster. And so they may meet some of these symptoms under criterion A and resemble a depressive episode. So we have to really take into consideration and appropriate them to the loss and see if this is a normal response to loss, or it is actually going out of the normal response to the loss and it is getting into major depressive disorder. So this category of patients has to be clearly and carefully considered. We can move on to the important specifiers. So the time at which symptoms occur and their duration may determine whether a specifier is applied in the bipolar diagnosis. So we may have bipolar diagnosis with anxious distress. So during the majority of days of the manic episode or hypomanic or major depressive, there should be symptoms of anxiety. So we have them, 2 or more of the following: feeling tense, unusually restless, worry, difficulty concentrating because of worry. So those are specifiers of bipolar disorder. And the other specifiers are rapid cycling. Rapid cycling is the presence of 4 or more mood episodes, in the previous 12 months, and they can occur in any combination or order. It doesn't have to be depression, mania, then depression, or depression, then mania. It can occur in any combination at any time, as long as they are 4 or more. And other important specifiers like atypical features, psychotic features. So you have someone with clear depression, but having delusions or hallucinations, and we have ruled out schizoaffective disorders. We have bipolar disorder with catatonia, seasonal pattern in remission, and so on. So when we go to challenges with diagnosis. Now, because of this overlap of symptoms, you can see from those specifiers that someone can come with anxiety, and yet you're seeing features of anxiety, and yet it is only a specifier of bipolar. They can come and they have substance use disorder, but it is affecting someone who already has an existing diagnosis of bipolar disorder. So we have to be very careful to make sure that we use our clinical judgment, and we also examine the history carefully. We look at the factors, and there are several factors which are associated with delays in diagnosis. That's gender, younger age of onset, the lifetime suicide attempts. This can make somebody misdiagnosed as bipolar disorder for depression, the comorbid anxiety, and previous misdiagnosis. So this illustration on the right is showing the different delays in diagnosis attributed to the different factors. We can move on to the consequences of delayed diagnosis. So a misdiagnosis of or delayed diagnosis of bipolar disorder is very possible, and it can cause administration of inappropriate treatment, increased hospitalization, increased wrong use of antidepressants, which can cause a mood switch, worsen mania, or prolong rapid cycling. It can actually cause rapid cycling. So we have to be very careful not to delay diagnosis or not to make the wrong diagnosis. So the key differential diagnoses, by this time, I think I've listed some of them. We go to the next slide. They include major depressive disorder, anxiety disorders, attention deficit hyperactivity disorder. So this figure is showing us the overlapping symptoms of bipolar disorder with this differential diagnosis, and then the bipolar specific symptoms on the right. The challenges. So next, why is it difficult to differentiate bipolar disorder from major depression? So it has always been a clinical challenge because, like we said before, the first episode many times is depressive. And across the course of bipolar 1, depressive symptoms are the most frequent. So what can you look at to see that is this patient going to be bipolar 1 or major depression? One is a family history. Two is if they have had several episodes of several past episodes of illness, whether depressive or manic. Three, first onset of the depressive episode. It just comes suddenly. Usually the major depressive illness, the onset is really gradual. Then presence of psychotic or manic symptoms, onset of illness by the early 20s, and of recent neurophysiological profiles are being suggested. So there are some cultural issues. There's not much studied in Africa, but in the Hispanic countries, the Americas, there's a lot of discrepancy between the different races and ethnicity. So these are the tools that we can use to support our diagnosis to ensure that it's the accurate one. Mood disorder questionnaire, the 32-item hypomania checklist, the HCL, the rapid mood screener, and the structured diagnostic interviews. We have to always make sure that we assess symptom severity, and the scales available are both the patient rated and the clinician rated. Why do we need this? Because it helps us to assess the progression on treatment. And in the developed countries, they're having smartphone-based self-assessments to generate daily estimates of clinical severity so that monitoring and treatment is improved. You can tell whether a drug is doing what it should or not. So this is my second last slide. I just want to highlight the importance of assessment and well, quality of life. We know that that is one of the biggest issues that the patients have. They want to know that their cardinal life areas are going to improve, that these areas like mood, sleep, physical activity, health, their cognition is going to be improved by the treatment, and that is a major marker of quality of life, but also functional outcome like home, work, education, leisure, financial management. Another assessment of quality of life takes into consideration the psychosocial functioning. So we can move to hiring this to the feature of bipolar disorder. I'll highlight this in the summary. Dr. Mwangzi, we can go to the summary slide. So there's a lot in here, and if it has even been compacted, you can always get the details on the Neurotorium website. But bipolar includes those disorders of emotion, thought, and energy, and it is usually in biphasic episodes. And there's a lot of misdiagnosis with other disorders, which calls for more accurate clinician judgment in order for us to give appropriate treatment. So let us remember that bipolar disorders are they're among the leading causes of disabilities in young individuals because they negatively impact functionality. The risk factors, we cannot forget childhood maltreatment, psychological stressors, substance use, occupational and socioeconomic status. And for the future, we are going to have to do digital phenotyping so that we can measure behavioral parameters in real time for improved management of bipolar disorder. Research is also looking at brain markers, which are being identified using neuroimaging to inform diagnosis of bipolar disorder and provide targets for personalized treatment. So apart from this treatment, the personalized treatment, we are also looking at having more culturally adapted tools for screening and treatment. Thank you so much for your patience. Thank you for being part of the sessions.
Thank you, Dr. Kemi, for a wonderful presentation. We did have some hiccups at the beginning, but we are glad that we are right on time. Members would like you to drop in your questions, your suggestions in the chat box so that Dr. Kemi can address them. We also want to recognize our faculty that is on board, Dr. Mwesiga Emmanuel, our PI, and Dr. Birabwa, Harriet Okecho, who is behind the Bipolar Association in Uganda, but also she has done tremendous clinical work in the area of bipolar at the Utalika National Referral Hospital. So we do recognize those. Maybe if we have time, we'll ask Dr. Virawa to give us one or two comments regarding this session. I know that this topic is really at heart for her. Let me check the chats to see if there are any questions. Yes.
Thank you, Raymond. I was actually thinking
Yeah, so let's go into the questions. Musa Muhammad, thank you for always being attentive and bring in your questions. The question is, how can we actually distinguish between bipolar depression and unipolar depression early in the illness to ensure appropriate treatment and prevent misdiagnosis? Dr. Kemembe, you can take it up.
Okay, so he wants us to be able to differentiate between bipolar depression and unipolar depression early in the illness. Okay, thank you for the question. It's an important one because we have seen that sometimes we give an antidepressant, yet it's actually bipolar depression. But we looked at some of those factors, and they included somebody whose depression comes on quite fast, a rapid onset of the depression. It also included a family history of bipolar disorder early in the presentation. If somebody has a family history, they are more likely to have bipolar depression than unipolar. Then if they have had numerous past episodes of depression, then it's important to also put a question mark, because they've had episodes, you've treated them, but they are recurring. So we need to observe for a manic episode as well. But also, if there are any psychotic symptoms, they are most likely, yes, it can be psychotic depression, but they are more likely to be a bipolar depression. And you look at the age of onset. We have said for bipolar, it is by early 20s. Maybe our content expert can add to that, Dr. Virawa, or
Okay. Again, we'll bring in Dr. Virawa towards the end. The other question we
okay.
have is from Bridget, who asks, how can we differentiate a manic episode from mood disorders, from alcohol intoxication or substance abuse?
How can you differentiate a manic episode
From
from
mood
mood disorder?
disorders, different from that of mania, that is alcohol-induced or substance-induced?
Okay, thank you very much. This is important in the outpatient or wherever we get our patients, because yes, we have looked at the high risk of misdiagnosis. And so it all goes back to the criteria. We have our DSM-5, we have our ICD-11 or 12, and so we go to that criteria and we look at the symptoms. Yes, the person with intoxication can mimic somebody with mania, but do they fulfill the rest of the criteria? Out of the 7 criteria listed in symptoms listed in criterion B, do we have 4 or more? Do we have changes? And remember, one of the criteria in DSM-5, we have to have that this in bipolar 1, D is saying we are not this symptom is not attributable to a substance or other medical condition. So apart from fulfilling the criteria in B, we have to exclude the substance as being causative. So my answer would be that we refer to the criteria for substance use disorder and for the bipolar disorder, and it will be very clear, much as the patient will come with similar symptoms or superimposed symptoms. Dr.
Thank
Mbuna, is
you.
there another question?
Yeah, from Dr. Diana Among, her question is, could peripartum depression be a predictor for future bipolar affective disorder in women?
Okay, thank you, Dr. Among. Peripartum depression, yes, it has actually been studied and identified that of peripartum depression have actually suffering for bipolar disorder. We are preempting the discussion, but we know that there's a
Dr. Kemirembe, are you still anywhere close to the microphone? I guess that question can be tackled on our next, maybe probably tomorrow. Again, I want to remind all our participants that we are starting a new series this week. It will run for 3 days, and it's about bipolar depression. Today we have talked about the definition, how you diagnose. Tomorrow, we'll have more about the neurobiology, and then on Thursday we shall be talking about management in general. Like I said, we do acknowledge our faculty. Would like to, let me check if there is another question. Yes, there is There's Wandera Joseph who says, what's the rationale for use of antidepressants in bipolar 2, putting into consideration of rapid cycling, and I've observed many practitioners use TCS, SSRIs in bipolar depression with no mood stabilizer. I think, Joseph, you keep that question for Thursday when we are talking about management, because tomorrow, once we understand the neurobiology, then maybe we can answer this question very, very well. But if you do forget, I will remind you myself. At this juncture, I would like to invite the PI who has the more courtesy to invite Dr. Virawa to give us 1 or 2 words. Thank you, Dr. Mwesiga. Is Dr. Mwesiga on call?
No.
Okay. If he's not on call, let me take the juncture to invite Dr. Virawa to give us 1 or 2 words of wisdom regarding the session today.
Thank you, Dr. Mugume. I'm actually a fly on the wall observing, but it feels good to be recognized. And I also want to recognize all the other participants. Thank you for attending. And these Neurotorium slides and presentations are actually very, very comprehensive. They make us look at disorders in really in details and certain things that you've never really thought about. So I want to congratulate the team, Dr. Emmanuel Mwesugwa especially, and also the team of the trainers. Thank you, Dr. Kemi Bhatkunda, for this very insightful presentation. And we are looking forward to learn more and more even in the coming days and for all the other disorders. My only comment would be related to maybe peripartum depression. I think we know now that the classification of peripartum, DSM-4 uses the word peripartum for a number of disorders, but we also know that for the psychotic disorders, bipolar is the commonest in the peripartum period. So it wouldn't be surprising that some people who are having peripartum depression could eventually become, they could have a manic episode in future, and then they change from being depressed to being bipolar disorder. The other comment I wanted to make is related to the manic episode and alcohol. Just an addition that actually some of these substances can cause a manic episode that may be in this, that you cannot distinguish from a bipolar 1 or a bipolar 2. That's why you have the diagnostic criteria of bipolar secondary to a general medical condition or bipolar secondary to substance abuse. The manic episode may not even be very different in terms of the criteria, except that in that case, you're talking about a manic episode being caused by a general medical condition or a substance abuse. And the other comment that is usually given is about depressive episodes in bipolar. Could have been on the slide actually, where the depressive episodes are likely to be associated with atypical symptoms like excessive sleep, increased appetite. That's more common in bipolar depression, in addition to what Kemi Bhatkunda said and also what has been given in the slides. And yeah, we are looking forward to the etiology, the treatment, and all the discussions. Thank you so much for giving me this opportunity to say something. And thank you all for the presentations and participation.
Thank you, Dr. Virawa, for giving us your time and also giving us clarification on some of the things that would not have been clear, and you made them very clear. We want again to remind our viewers, our participants, that all these materials are at the neurotorium.org website, where so far we've covered substance use, depression, schizophrenia, and other psychotic disorders. So you can feel free to go there and download the slides. We're just delving more into the neuroscience aspect of this. We'll be here again tomorrow from 7 to 8 p.m. Without a delay. We are promoting better time management, and we're just left with 3 minutes. If there are any other questions that could be directed to the speaker in these 3 minutes, they are welcome. But if they are not, I would like to bring this to a close and wish all of us a good night, and see you tomorrow at exactly 7 p.m.
Dr. Mugume, there is a question in the chat. I wish Dr. Biraba could again help us to address it. It's the very last question that was asked. I think it was skipped.
Yeah. I think the question on rationale for use of antidepressants, we said we could leave that until we discuss the treatment. We are preempting you to come for more, I think. I think that's what Dr. Mugume had said.
Absolutely, absolutely. That once we understand the biology, which will be tomorrow, and then the management, then we can have this question. I'll endeavor to have it back for Mr. Joseph to understand it.
Well, maybe for the sake of people who may not be able to attend, ideally you're not supposed to use antidepressants in bipolar 2, even if they have mood stabilizers are the best, especially lamotrigine. It has more use for bipolar 2 and depression. And using TCS can be very risky because you can manic episode. SRI is better than, so using TCS SRIs with no mood stabilizer is usually not recommended. But we shall get the details probably, and other new things that we can use like the Rulasudone and other mood stabilizers.
Thank you, Dr. Birawa, for again clarifying on that subject. And someone asks if we can rewatch the session recording. Again, you just register and stick to your email we shall be sharing with you. Ladies and gentlemen, I would like to call this to a close. I'll see you tomorrow at exactly 7 p.m. Bye-bye.